Good morning and welcome to the Center for Spirituality and Health's Grand Rounds. My name is the Reverend David Fleener and I'm the Director of Education for the Center. We're delighted that you could join us today. I'd like to add a special welcome to those who are joining us through Facebook Live. Before we get started, please take a moment to silence your electronic devices, and if you do receive a call during the presentation, kindly step out to take that call. Our guest speaker today is Dr. Tracy Balboni, who currently serves as an Associate Professor of Radiation Oncology at Harvard Medical School and acts as Director of the Supportive and Palliative Radiation Oncology Service at the Dana-Farber Brigham and Women's Cancer Center, a service dedicated to the palliative radiation therapy needs of cancer patients. Dr. Balboni provides leadership to the Initiative on Health, Religion, and Spirituality at Harvard University, together with Tyler Vanderweel and Michael Balboni. Her primary research interests are located at the intersection of oncology, palliative care, and the role of religion and spirituality in the experience of life-threatening illness. Her work also includes forging improved dialogue between academic theology, religious communities, and the fields of medicine. She's the author of over 80 peer-reviewed publications, including several groundbreaking articles related to spirituality and health. Her topic today, as you can see, is the state of the science of spirituality and palliative care. So without further ado, please welcome me in joining Dr. Tracy Balboni.
Great. Thank you, David, and thanks all of you for being here and being a part of this event today. I've been here since earlier this morning and have had a chance to speak with some of you and learn a bit about the Center for Spirituality and Health and your chaplaincy department, and it's just amazing. It's amazing to see the work that you're doing here and to have this morning to be a part of it. As the title suggests, I'm going to be speaking to you about the state of the science in spirituality and palliative care because, as you all know, in order to move things forward, we have to understand where we are now. And so that's really what I'm going to be doing today, is trying to help us to understand where we are today in order to help us to understand how we might see opportunities and take opportunities to move steps forward. But before I even begin with that, I want to just ask this very basic question, which I think maybe isn't necessary for this audience, but I think is still helpful to state, and that is, well, why does this matter? Why does it matter to move this field forward to advance the science of spirituality and palliative care? And as you all likely know, palliative care actually is defined to include attention to spirituality and spiritual care. As we see in the WHO definition of palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And so spiritual care is understood really as a core domain of the care of patients and their families facing serious illness. And of course, we see that within the National Consensus Project, the guideline-setting body for quality standards within palliative care within North America, includes these 8 domains of palliative care, and the 5th domain is the spiritual, religious, and existential aspects of care. These are sort of larger guideline-setting organizations, but let's just take it to the everyday, and through persons like Dame Cecily Saunders, who's really one of the founders of the hospice and palliative care movement, who in the 1960s articulated the concept of total pain. Pain that is not just comprised of the physical, but also emotional, social, and spiritual sources. Or Eric Cassell in this landmark article, The Nature of Suffering and the Goals of Medicine, published in the New England Journal in the early 1980s. Who says that in this article, transcendence is probably the most powerful way in which one is restored to wholeness after an injury to personhood. And this article, as you may be familiar with it, it discusses how illness and suffering is really a threat to one's personhood. And transcendence, when experienced, locates this person in a far larger landscape. The sufferer is not isolated by pain, but is brought closer to a transpersonal source of meaning and to the human community that shares those meanings. Or in just the simple words of Daniel Slomacy, a internist and philosopher, in his book, The Rebirth of the Clinic, illness is a spiritual event for all persons, regardless of, just because of the myriad of spiritualities that are experienced by individuals. We all have a form of spirituality, a form of meaning making, and because of the ways that illness threatens that central aspect of personhood, illness is a spiritual event. But then finally, of course, it's in the words of our patients. This is one patient who we interviewed as part of a study in the mid-2000s, who was responding to the question, first we asked, has religion or spirituality been important to your experience of your advanced cancer? The vast majority, 78%, indicated yes, that it had, that it is, and then those patients that indicated it was important, we asked them in an open-ended fashion, well, how? How has religion or spirituality been important to your experience with your illness? And this is a 46-year-old gentleman married with 2 young children, and he says, since being diagnosed with cancer, the way my wife and I pray together has become a lot more clear, and we have made our faith the absolute center of our lives with our children. If it weren't for my faith, I don't know how I would have kept my equilibrium through this process. It is definitely through grace. My natural state of anxiety and manic nature would have spiraled out of control by now if it wasn't tempered by grace. It is profound. And indeed, it's profound. I mean, we see these words of Cecily Saunders or Eric Cassell, Daniel Slomacy, and then of this patient, and we see the profound ways in which spirituality can be a source of wholeness. Of course, we also see how spirituality can be a source of pain for patients. And yet, I think we all acknowledge that there are ways in which medicine continues to neglect this aspect of the patient experience, and that we have a long ways to go in order to better be embracing this aspect of patients' experience, particularly in the setting of an advanced illness. And it's with this in mind that the National Palliative Care Research Center, headed up by Sean Morrison, had the vision to move the state of the science further by funding a gathering of key spirituality and palliative care research leaders to consider these issues. First, naming and attempting to address some of the key conceptual questions and approaches that are relevant to the study of spirituality and palliative care. Also to provide an overview of the research landscape with a particular attention to places where they're naming key gaps. And then finally, based on that, identifying key research priorities and critical next steps in the field to push the field forward. And this has been published in 2 publications in the Journal of Pain and Symptom Management in 2017, just this last year. These were the participants. This was led together with Karen Steinhauser from Duke, together with a multidisciplinary group of leaders in spirituality and palliative care, including from chaplaincy, George Bichette, George Hanzo, Shane Sinclair, who also has expertise in nursing, together with Elizabeth Taylor, psychology and methodology from both Karen Steinhauser and Kenneth Pargament, a variety of physicians representing different disciplines from mental health to palliative care to disparities in end-of-life care, including Kim Johnson, Harold Koenig, Christina Pukalski, and then Christina Pukalski also assisted in providing expertise in education. And really the goals for that session are our goals for today. I'm going to be taking you through sort of the basics of the outcomes of those efforts, naming key conceptual questions and approaches, providing an overview of the research landscape so we understand kind of where things are today, and then naming some key research priorities and next steps, which kind of are a springboard off of that current research landscape. And then I want to leave plenty of time for discussion for all of us as well. So first, key conceptual questions and approaches. We really understood 2 primary conceptual issues that are kind of hampering moving the field forward as far as understanding the role of spirituality in the experience of serious illness, as well as the integration of spiritual care into the care of patients and their families facing serious illness, And one of them is definitions. One is simply, what is spirituality? Spirituality in many ways is ineffable. It's very difficult to define, and when you're attempting to understand spirituality and its role in the setting of illness in a rigorous way, you need rigorous definitions. Well, how do you do that? How do you arrive at a rigorous approach to definitions when spirituality is by nature something that's difficult to measure? Another issue is just in general methods and measurement in this regard. What guiding principles should guide our approach to research in spirituality and palliative care? So first, in regard to definitions, we do have the International Consensus Conference definition, which names spirituality as a dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, transcendence, and experience relationship to self, family, others, and the significant or sacred. It's expressed through beliefs, values, traditions, and practices. So you can see this is a very appropriately broad definition. It's attempting to capture the myriad ways in which spirituality can function in the life of a variety of different types of persons and cultural backgrounds. And but honestly, it's a researcher's nightmare. There's so much in this. I mean, my goodness, it's dynamic, it's intrinsic, it's about ultimate meaning, purpose, transcendence. It's about relationships, but not just one type of relationship, multiple types of relationships, self, family, others, and the significant or sacred. It's also expressed in a variety of ways, including beliefs, values, traditions, and practices. So how in the world, as a researcher, does one approach attempting to understand this, to measure it, and understand how it's related to other constructs? And some have attempted to get at, well, is there sort of a central element of spirituality, a core? This is Kenneth Pargament's idea of a sacred core, through which all these other dimensions are then relating. There's sort of a sacred core, and then we might have the communal aspects of that, or ways in which it fosters individual meaning or purpose or relationships. But it's all really about this central sacred core. Or others have provided a more complex sort of way that they're related to one another, where there might be this, maybe not a sacred core, maybe it's more about ultimate meaning, value, or purpose that's at the center, and then it's layering out into first the individual human experience, but then also human relationships, and then ultimately into cultural and social experience and institutions. The bottom line here, I'm giving you just two sort of schematics of how one might begin to conceptualize the definition of spirituality. But the bottom line is that it's not really well understood. These are interesting ideas, but we don't know. We need to continue to test them in order to fully understand and grasp what spirituality can be understood as within the human experience. What we did find within the literature is that clearly spirituality is multidimensional. I think we've already, seen that within even the schematics that I've provided. And if you look through the literature, there are core dimensions of religion, spirituality, and palliative care that I think one can arrive at these as sort of a preliminary set. Clearly there need to be more research, and there likely will be more, but some core dimensions include the importance of religiousness and spirituality, the extent to which it is a central feature of someone's life and daily experience, and also, of course, a central feature of one's experience of one's illness. Also, religious or spiritual affiliation or identity with a larger cultural group, and how it impacts religion or spirituality, how it impacts coping, whether in positive or negative forms. Also spiritual experiences, again, whether in positive or negative form. There might be ways in which spiritual experience might lead to peace and meaning, purpose, forgiveness, but then also there could likewise be needs, such as a feeling of being abandoned or punished, that are stemming from one's spiritual experience. There also can be sort of a framework of spiritual, religious or spiritual values and beliefs that are related to one's religion or larger religion or spirituality, providing us a framework for understanding life, and therefore also a framework for understanding one's illness. And then finally, religious and spiritual practices. ways in which one's spirituality is practiced, whether through reading of ritual texts, fasting, and other types of practices. So these are sort of 6 core dimensions of religion and spirituality that are seen in the literature, that are frequently tested, and certainly provide an initial framework for how one might understand spirituality as in a multidimensional fashion. So again, spirituality clearly is a multidimensional construct, but the definition is unsettled. And really we should see research as opportunities to further refine our understanding. Not to be overwhelmed by the large definition, but rather to begin to tease out how these different dimensions of spirituality are related to outcomes. And I think it's also important to keep in mind that there is a distinction between a clinical definition and a research definition. So a clinical definition, often one is aiming to be as all-encompassing as possible, as we saw in the International Consensus Conference definition. But in a research setting, it's appropriate to be naming the specific dimensions, and maybe you're going to be more circumscribed than that International Consensus Conference definition in order to be very particular about how you're examining what dimension of spirituality is related to what outcome. So, just in summary in regard to an approach to definitions, I think it's important to always be stating the definition of spirituality on which the research is being based. We need to state the dimensions of spirituality. As we've noted, spirituality is a multidimensional construct, so we need to state the ones that we're actually investigating. And then we need to be matching measures to the specific dimensions that are being investigated. And then we need to be considering where that definition of spirituality, or where the dimensions of spirituality that we are measuring are overlapping with other psychosocial domains, and we need to measure those. So we can begin to refine how our understanding of that particular dimension is related to our outcome. If there's the potential for confounding with another factor, we need to be measuring that simultaneously. So that's sort of a very brief overview of issues of definitions of spirituality within spirituality and palliative care research. Well, what about methods and measurement? I think that the approaches here are applicable to research in any setting, but something that we need to be cognizant of as we are doing research within spirituality and palliative care. So first, we need to understand what our study purpose is. Is this clinical screening? Is this outcomes research? Is this about quality improvement? And is this about institutional accountability? And then within that purpose, we need to identify what our conceptual model is, which needs to be articulated a priori. We need to state what our definition of spirituality is. Again, what the dimensions are that we're studying, and then positing what the relationships will be to the outcomes that we are measuring. And then again, measuring potential confounders as well as potential mediators of those relationships. Of course, we need to be identifying the dimensions of our assessment and then matching our measures with those particular dimensions. So this is sort of just a rapid overview of how we might approach spirituality and palliative care research in a way that's rigorous, in a way that helps to create a better understanding of what dimensions of spirituality we're measuring and how they are indeed related to outcomes in a way that helps us to differentiate it from particularly other psychosocial domains that are relevant to that particular outcome within palliative care. So with that, I'll turn to an overview of the research landscape. And just as I've stated that it's important to state your conceptual model, I'm going to actually place this research landscape within a conceptual model. And we'll begin with our patient and patient spiritual dimensions. And I think from the research literature, we can indicate that clearly spirituality is impacting a number of important outcomes within palliative care. So, for example, quality of life, even medical decision making, and the types of care that patients are receiving at the end of life. We also have family spiritual dimensions, and of course we can posit that although there isn't much research in this area, that patient spirituality and family spirituality are likely in dynamic relationship with one another. And these likewise can impact family outcomes. But let's kind of build our model further. Clearly, patient outcomes, for example, whether a patient ends up passing away in an ICU setting versus a hospice setting, are they interfacing also with family outcomes, bereavement outcomes, et cetera. So there is quite a bit of research literature regarding those sorts of relationships. Extending it further, we also have medical teams caring for patients and caring for families. In the entire medical team, whether it's physicians, nurses, chaplains, social workers, et cetera. They have the opportunity to be interfacing with the spiritual dimensions of a patient's illness that can go on to influence patient outcomes. Similarly, they can be interfacing with families in their spiritual dimensions and influencing family outcomes. And you can imagine that there might be ways that medical teams' provision of spiritual care, their attention to the spiritual aspects of illness may actually influence their own experiences. So for example, burnout. There's some literature that suggests that clinicians who have greater sort of connection with their patients, including sort of a suggestion of sort of a spiritual connection with patients, may have less burnout. Those that experience more meaning in their work, for example, also experiencing less burnout. So some suggestion that there could be a relationship there as well. And you can imagine that that may also influence how patients are being cared for spiritually and ultimately their outcomes. And we can imagine that would also influence not only patients but families. But let's also turn to the community setting. What about community spiritual care providers? They also are going to be influencing patients' experience and, of course, families as well. And one can imagine that there might even be an interplay between, and hopefully more bridges that are created between the community setting and medical teams that could also be ultimately impacting some of these outcomes as well. So this is, quite a complex conceptual model. But I think that that's a place to start in order to understand what research is present and to begin to identify where we know quite a bit and where we need to deepen our knowledge and take next steps to move the field forward. Of course, we also have, I didn't mention faith community spiritual care outcomes as well. I mean, we can imagine that as communities are better connected with medical teams and providing spiritual care to practitioners, we can also impact how they are ultimately providing spiritual care to their practitioners, which will ultimately impact both patients and families. So I'm going to be focusing here and actually providing you with some example research points that I think illustrate some of the ways in which these connections are actually happening and present within the literature. So first, patient spiritual domains and their relationship with a variety of patient-centered outcomes within in the care of patients with serious illness. So first, I have these 6 domains or 7 domains of patient spirituality in the setting of serious illness. So first, spirituality. A number of studies in a cross-sectional fashion, these dashed lines here indicate a cross-sectional relationship, have indicated that patients, a variety of measures of spirituality are associated with improved quality of life in the setting of serious illness. Interestingly, measures of religiousness have not found that same association. That's shown in the gray line here. Again, only studied cross-sectionally, however. Interestingly, however, religiousness has been, in a cross-sectional fashion, been shown to be associated with beliefs in desiring more aggressive end-of-life care in a cross-sectional fashion. And in a similar fashion, positive religious coping has been found to be associated not only with greater preferences for aggressive end-of-life care, but ultimately in a prospective fashion, greater receipt of aggressive end-of-life care in patients with terminal illness. Negative religious coping, which is sort of a spiritual struggle or beliefs that are, or ways of coping which are kind of indicating a religious struggle for the patient with their illness have, as you might imagine, been associated with worse quality of life for patients. Similarly, spiritual needs have been associated with worse quality of life for patients. A more recent area of investigation has been that of religious values and beliefs in illness, which have been associated with greater preferences for aggressive end-of-life care, as well as some suggestion of greater disparities in end-of-life care, particularly for certain minority groups. I think one thing you can note here is, as we kind of consider a snapshot of the overall literature, is most of these lines are dashed. And the dashed lines mean that these are all cross-sectional relationships. Only one of them here is solid, so there's not a lot of prospective data for us to be working with in this regard. And then some of these have very little literature to support them. So, for example, in the realm of spiritual needs and quality of life, as well as spiritual practices to any of these outcomes. So this sort of points out some areas of clear need as well.
The numbers in parentheses mean?
Those are sort of a variety of references.
Okay.
Yeah.
I'm sorry, could you briefly explain the difference between prospective and cross-sectional?
Sure, so a cross-sectional study is when the assessment is done at this, of both entities, both the predictor and the outcome, are done essentially at the same time. So you can only claim an association between the two, but you don't know what direction they're going in. Whereas in a prospective fashion, you're measuring your predictor at an initial time point, and then at a subsequent time point, measuring the outcome. And which allows you to say a bit more about the potential for causality than a cross-sectional association can. So this is sort of a schematic of the research literature that's available regarding the relationship between family spiritual domains and family-centered outcomes in the setting of a loved one with serious illness. And I think the first thing you can take from this is that there's not a lot of literature in this regard. There needs to be a lot more in the realm of caregiver well-being and caregiver spirituality as they're caring for a loved one with serious illness. But of the research that is available, much of it is measuring the domain of spirituality and its importance to patients. And there's data that suggests that it is associated with improved patient quality of life as well as improved bereavement outcomes. Also here, positive religious coping is associated with improved quality of life. There isn't data related to negative religious coping. Spiritual needs, however, has been associated, perhaps not surprisingly again, here with decrements in patient quality of life. Spiritual practices has been tested in the family or caregiver setting and been associated with improved quality of life. But again, these are all cross-sectional data and much less data in this regard describing these relationships. So now I want to drill down into a few of these studies. I've provided this sort of broad overview, but just want to give you a few examples. So first, in regard to the relationship between patient spirituality and quality of life, this is a multi-institutional cross-sectional study of over 1,600 cancer patients. These were actually all stages of cancer, and spirituality was measured with a validated scale, the FACIT-SP, and found to be an independent predictor of quality of life, even after controlling for other important predictor variables such as physical well-being, emotional well-being, social well-being, and disease and demographic variables. But again, this is a cross-sectional study, so we can't assume the directionality that's here. And another issue with any literature examining spirituality and quality of life is a lot of the questions about quality of life have some conceptual overlap with many of the questions regarding spirituality. And what if they really are measuring the same thing or have some overlap with one another, of course they're going to be related to one another. But one way around that is in this national survey-based study done by Karen Steinhauser of over 1,800 seriously ill patients, where they simply asked patients, what is most important to your quality of life at the end of life? And they gave patients, they also surveyed other members, such as family members, physicians, and other care providers. So that focusing on the patient data, asked them what's most important to your quality of life at the end of life, providing them with 44 potential attributes. And this table from the manuscript provides the top 9 of those 44. And as you can see here, the top 2 are being free from pain and being at peace with God. So the top 2 of those 44 include really a spiritual construct, that of being at peace or being at peace with God. And actually the authors comment in this that these sort of statistically tied for first with one another. So just supporting, now we have, patients' actual perceptions or naming what's most important to their quality of life at the end of life, including really a spiritual construct, being at peace or being at peace with God. Or how about this relationship between spirituality and medical decision making? Just to give you a few examples of this, this is a study of patients with advanced lung cancers, their family caregivers, and then 257 medical oncologists caring for patients at those same institutions where those advanced lung cancer patients were being cared for. And each of these 3 groups were asked to rank 7 factors important to the patient in making their treatment decisions. So of course patients were responding as to what was most important to them, but then the family caregiver and the medical oncologist were anticipating how the patient would rank those 7 factors. So these are the 7 factors: the oncologist treatment recommendation, the ability of the treatment to cure the disease, the side effects of the treatment, the family doctor's recommendation, the spouse's recommendation, the children's recommendation, and then the patient's faith in God. And I'll just highlight for you here that everyone agreed that the ability of the treatment to cure the disease was the #1 factor. So that's patients, the family caregiver, as well as the medical oncologist. But then next for patients and for families, but then last for physicians, was patients' faith in God. So illustrating that, patients understand this to be very important to their medical decision making. The family caregiver also understands that it's important to their decision making, but the physician clearly doesn't see that ordering. And in fact, understands it to be last among these 7 factors. But of course, does that really impact the types of decisions that patients are making in their end-of-life medical care? And this study, from the Coping with Cancer study headed by Holly Prigerson, would suggest yes, it does. This is a study, a prospective cohort study of patients with advanced cancers with an estimated prognosis of less than 6 months, where at baseline they measured a number of psychosocial and spiritual factors. And one of the spiritual factors that they examined was religious coping. I mentioned to you religious coping is one of the key domains of spirituality within the setting of serious illness. So at baseline they assessed spiritual coping with a validated scale, Ken Pargman's R-COPE scale, and then prospectively followed patients to the end of their lives and examined the types of care that patients ultimately ended up receiving at the end of life. And in particular, looking at forms of aggressive medical interventions in the last week of life. And so I'll just point out to you here that the high religious coping patients is actually just a median split on the scale. So those scoring the median or higher are shown in the blue, and the low religious coping patients are shown in the yellow. And we can see across the board here of these sort of aggressive medical interventions in the last week of life, that those that exhibited high religious coping at baseline are receiving greater intervention. So for example, ventilation, resuscitation, and ultimately dying in an ICU were all greater among those high religious coping patients. These are the raw data, but even in adjusted analyses, adjusting for other potential confounding factors, these relationships persisted. So suggesting that spirituality, we saw in the prior study that patients are perceiving that their faith is interfacing with their medical decisions, but here we're actually seeing that they are, in fact, they are related to one another, that patients are actually making decisions that are clearly related to their religious coping. So, of course, this caused us to sort of dive further. Well, what is it exactly about one's spirituality, one's religiosity that's causing patients to make these medical decisions? And one hypothesis is that it's religious beliefs about end-of-life care that are interfacing, that are these sort of interface or the mediator between religiousness and the receipt of aggressive medical interventions in the last week of life. So as part of the Coping with Cancer 2 study, a separate population but very similar, advanced cancer patients, less than a 6-month prognosis, headed by Holly Priggerson. We examined 275 of those patients and specifically asked questions related to whether they had religious beliefs or values that were impacting their end-of-life medical decisions. And these were based on beliefs and values that were seen in the literature, largely case reports. I'll take you through those questions in a moment. And those patients indicated their degree of agreement with those religious beliefs or values about end-of-life care, from not at all to a great deal. And these are the beliefs, the religious values and beliefs. So first, my belief in God relieves me of having to think about end-of-life medical decisions, endorsed by 57%. I'll accept every possible medical treatment because my faith tells me to, 65%. Agreeing to a DNR order is against my religious beliefs, 11%. I'm giving up on my faith if I stop treatment, quarter of patients. God can perform a miracle and cure me, 2/3 of patients. I must endure medical procedures because suffering is God's testing, just over a quarter of patients. And then faith helps me endure suffering from medical treatments, 70% of patients. But I think what you can immediately glean here is that these religious beliefs about end-of-life care are endorsed quite commonly. And in fact, 87% endorsed at least one of these items, and 62% endorsed 3 or more. And perhaps not surprisingly, greater religious beliefs about end-of-life care predicted for a reduced understanding and acceptance of one's illness as terminal. So this is sort of a suggestion that perhaps this is one of the links between patient religiousness and the types of medical decisions that patients are making at the end of life. So we've sort of focused on the patient data. I now want to turn and provide a few examples of caregivers and how spirituality influences their outcomes. This is the REACH study, Resources for Enhancing Alzheimer's Caregiver Health study of over 1,200 family caregivers, in which they measured faith and spirituality. They actually did a multi-dimensional measurement and then assessed how it related to both depression as well as complicated grief. The majority of this caregiver population considered spirituality and faith to be important, and in adjusted models, its importance as well as spiritual practices, attendance of religious services were each associated with reduced depressive symptoms as well as less complicated grief in bereaved family caregivers. So we've focused here. I've provided some examples of how patient spiritual dimensions are related to patient outcomes, quality of life, and types of medical decisions and ultimate medical care received at the end of life, as well as family spiritual dimensions and how it relates particularly to quality of life outcomes. I do want to expand this a bit and consider also how medical teams and their provision of spiritual care might be impacting these outcomes, as well as community spiritual care and how it influences outcomes. And here again, there's really a paucity of data to guide us, but just to provide you with sort of an overview of what is available. We do have data that suggests that where medical teams receive spiritual care training, they are more likely to provide spiritual care. Of note, spiritual care training is fairly infrequent, but again, when it is provided, medical teams tend to provide more spiritual care, more referrals to chaplaincy, more spiritual history taking, etc. Where medical teams provide spiritual care, You see here with the solid line, it's a prospective relationship. It's associated with improved patient quality of life. And it's also associated with less aggressive end-of-life care, also in a prospective fashion. As far as faith communities and its impact on patient outcomes, faith community spiritual care is actually associated with improved patient quality of life, at least it's suggested in a cross-sectional fashion. But spiritual care to patients and families is actually associated with greater aggressive care at the end of life. And I'll take you through some of these examples in a moment. So again, as part of this coping with cancer study, just again, this is a prospective multi-site study of advanced cancer patients, which was designed to examine psychosocial and spiritual factors and its relationship to end-of-life outcomes. It not only looked at patient spiritual domains, I spoke to you about its measurement of patient religious coping at baseline, but it also assessed spiritual care. And it specifically assessed support of spiritual needs by medical teams, including doctors, nurses, chaplains, etc., so the entire medical team, support of spiritual needs by spiritual communities, and then also receipt of pastoral care visits. And outcomes was caregiver assessed quality of life as well as medical care received in the last week of life. So this is the relationship between baseline reports of medical team spiritual support and quality of life at the end of life. So moving from left to right here, we have first the measure of spiritual support from the medical team. Those in the blue are reporting high spiritual support from the medical team. And on our y-axis, we have the caregiver rated quality of life in the last week of life, which with higher numbers meaning better quality of life in the last week of life. And you can see here, these are adjusted analyses that patients receiving or reporting high spiritual support at baseline have better quality of life in the last week of life. A very similar relationship for pastoral care services. And then finally, kind of summing it up here, this is the blue here is any receipt of spiritual care, either having a medical team that's highly supportive of your spiritual needs or seeing a chaplain versus the orange here would be none, no form of spiritual care that's reported. Those patients actually have the greatest improvement in their quality of life as compared to those that had not received any form of spiritual care. So suggesting that patients who are receiving spiritual care it ultimately improves their well-being at the end of life. Go ahead, your question.
So is this chaplains, pastoral care, or is this clergy, community?
This is all chaplains.
All chaplains.
This is all in the medical setting. That's important clarification. So what about spiritual support and end-of-life medical care outcomes? So mind you, high spiritual support from medical teams was a minority of patients who reported this, perhaps not surprising. Only 26% of patients reported that they were highly spiritually supported by their medical teams. But when it was present, those patients received more hospice and had less aggressive interventions, being resuscitated, being ventilated, being admitted to an ICU, and then ultimately were less likely to die in an ICU setting. And it's important to note that the impact of medical team spiritual support on end-of-life care is largely seen in those high religious coping patients. Remember, I showed you earlier the data where patients who exhibited high religious coping at baseline were more likely to receive aggressive care at the end of life. It's when those patients are interfacing with a medical team that provides spiritual care that they no longer have that greater risk of receiving aggressive end-of-life care. They're actually more likely to transition to hospice care, etc. But what about the relationship between high spiritual support from religious communities, which is more frequent, 43% of patients reported this, and end-of-life medical care outcomes? Those patients, the relationship is the opposite, less hospice, greater aggressive interventions, and more deaths in an ICU setting. And those findings are in fact stronger in our high religious coping patients. And as I mentioned to you before, one possible reason for this association perhaps is those religious beliefs about end-of-life care. Perhaps religious communities are reinforcing religious beliefs such as the miracle or importance of sanctity of life, etc. And that is actually reinforcing for those patients, for those religious patients, making decisions for greater aggressive care at the end of life.
Tracy, what is the high spiritual support? What do you mean by that?
So, that's actually one of the primary weaknesses that you're naming, which is that this is what patients named as high spiritual support from their religious communities, but what they were actually receiving from their religious communities is not known. We do know that it's, so for patients reporting high spiritual support from their religious communities, they're more likely to be visited. But that's the only piece that we have to describe what was actually happening in those interactions.
And that's true for the chaplain visits too?
So yes, so when those patients who reported high spiritual support from their medical teams, what we know is those patients were also more likely to receive chaplaincy visits, to have a chaplain integrated into the team. Go ahead.
Could you leak a little bit of a report coming out about the quality of the religious community being conservative, liberal, or evangelical, or whatever? Because I know,
Yeah.
Michael is working with that. Can you leak a little bit of that?
So, I don't think it's leaking, but there was a fairly recent national study of clergy, which actually took those religious beliefs about end-of-life care, and asked clergy the degree to which they would endorse those beliefs if their parishioner indicated them. So it's sort of a proxy of a human relationship. How much would they support a patient in saying, I believe that I can be cured of, a miracle will happen and I'll be cured of my cancer, as an example. And as you might imagine, more conservative, particularly more conservative traditions, Christian traditions, et cetera, tended to endorse those beliefs more as compared to mainline or more liberal traditions, as you might expect. So just a summary of this sort of research landscape. We're seeing that patient spiritual dimensions are related to important outcomes, things like quality of life, also their medical decision-making, and even the care that patients are receiving. We have, much less data in regard to caregiver spiritual dimensions and outcomes, but certainly data that suggests that it's related to important quality of life outcomes, their quality of life, their bereavement, et cetera. We're seeing that medical team spiritual care is related to patient outcomes, including patient quality of life, as well as the types of medical care that patients are receiving at the end of life, and also a suggestion that that faith community spiritual care may also be influencing outcomes, and in particular, perhaps patient medical decision making and outcomes. Actually, one other piece from that data, from the clergy data, that was quite surprising to us is the frequency with which clergy were actually engaging in end-of-life discussions about the medical decisions that they were making. So it was the majority of clergy who are caring for dying congregants. They were called the last congregant that they provided spiritual care to. The majority of clergy are actually discussing their end-of-life medical decisions with their congregant. So it's actually quite common that they're engaging in these conversations. But clearly, and I hope I've pointed this out well in providing this sort of overview of the landscape, there are many unanswered research questions that remain. So with that in mind, I'm going to just name in the next few minutes just some key next steps and research priorities. Clearly some gaps, which I've attempted to highlight along the way, are this lack of rigorous methods. Oftentimes, definitions have not been named in these studies that I just took you through. Most of them have lacked clear conceptual models. It's very infrequent for there to be multidimensional assessment of spirituality. As we saw, there's infrequent prospective designs, certainly not multiple time points of assessment. And infrequently simultaneous assessment and rigorous assessment of potential confounding variables. We also need greater diversity, whether it's illness type. Much of the data that I showed you is from the cancer care setting. Also, we need more data within caregivers, certainly geography, culture, race, ethnicity, et cetera. There needs to be greater diversity in this research. We also, there are many sort of key, gaps regarding how spirituality is actually influencing these outcomes. And certainly other key outcomes really haven't been studied at all. So for example, not just the types of care that patients are receiving at the end of life, but what about their goal attainment? If a patient desires to die at home, are they dying at home, et cetera. So ensuring that it's a patient-centered assessment of the types of outcomes such as medical care at the end of life, and certainly caregiver outcomes as well. We also have, in regard to spiritual care providers, a little study of medical teams as well as faith communities and how they're impacting patient and family outcomes. I've provided you with, a few data. There's some data that's there, but clearly there's much more work to be done in that regard. So this is a very busy slide, and I'll walk you through it, but this is sort of an actual table of naming key research priorities in spirituality and palliative care research. One, we need clarity of definitions. We need named definitions to understand what we're actually studying, and then naming what the dimensions of spirituality are that are being measured. We need clear conceptual models to guide research, as well as to guide what measures are used. We need to include measurement of key confounders, as well as potential moderating factors, and of course we need rigorous designs. Some sort of key priority areas for research include research that really gets at the mechanisms of the relationship of spirituality to key outcomes like quality of life. We need further study of religious beliefs and values and how that's influencing medical decision making and other care outcomes, in particular outcome disparities. And we also need more work in the realm of spiritual needs. I didn't take you through much of these data, but there are data that suggest that spiritual needs of patients with serious illness are very frequent. And there isn't much data both on just, certainly description, but even how that impacts outcomes. And as far as medical teams and faith communities, we need data which look at how spiritual care influences patient quality of life outcomes, how it influences care decision making, how it influences and perhaps mitigates end-of-life care disparities, and how it might influence patient and family satisfaction with care or communication effectiveness. And then there's a whole realm within how we go about sort of the practical aspects of spiritual care provision, which also needs much work. And that includes screening, assessment, actual spiritual care interventions, and education. So we need studies which define optimal spiritual screening, history taking, and assessment. We need a lot of work within chaplaincy to define best practices in patient care. And certainly more work on interventions for patients and families, particularly patients and families in need, that are actually translated into scalable practice models. And then finally, we need all of that translated into education, defining spiritual care competencies for clinicians, having evidence-based spiritual care curricula, so spiritual care curricula that are based on the evidence that's available. And of course, we need to assess the impact of that education ultimately on outcomes. So just in conclusion, clearly spirituality is poorly understood, but it's critical to patient and family quality of life and outcomes, and certainly to the practice of palliative care. And we need to be applying rigorous conceptual approaches, including defining spirituality, grounding research in a stated conceptual framework that's based on the evidence base that's available. And thus far, we can see that the research landscape has many compelling findings regarding the role of spirituality in patient and family quality of life, care decision making, et cetera, but there are many gaps that need to be addressed. And so hence we've named these research priorities to guide future research efforts. I do want to again acknowledge the funding and really the vision. In fact, Sean Morrison is here with us today of the National Palliative Care Research Center. They really were the ones to recognize that this is a key area that needs to be moved forward in palliative care, and it was as a result of this support that this effort even went forward. Of course, my co-leader, Karen Steinhauser, as well as the other participants in the State of the Science Conference. Other funding from foundations, as well as the friendship and work of key mentors, colleagues, and friends. And also thanks to you all for your attention today, and I welcome questions in our last few minutes.
I want to go back to the definitions. I think, in all these studies, we shoot ourselves in the foot because of grammar. the confusion with spirituality and the spiritual domain. People make spirituality, which is a way of hooking into the spirit, and they confuse the spiritual domain with spirituality. Spirituality is more of a verb, how you relate to the things of your spirit. And I think that clarification, it causes more confusion in trying to study it. So if people would use the language, the spiritual domain has these factors, and how people enter it is their spirituality. So if you're studying how people enter the spiritual domain, at least make the clarification, what are the boundaries of the spiritual domain? Now, maybe I'm just stuck in my own conceptions, but I think every time I read these articles, I have to do that mental gymnastic, because people are confusing the spiritual domain with how people relate to it.
Yeah.
Anyway, I offer that up.
I mean, you're just I mean, that is a key issue is first circumscribing the domain.
Yeah.
I mean, because I think one problem is that oftentimes when it's not defined or just so broadly defined that it ends up, it's not clear what exactly you're measuring and if you're actually measuring other psychosocial domains. But then, I mean, as far as your particular way of approach, one could argue, well, okay, then try that approach and test and see how that works and what different information that you obtain. You might want to begin with focus groups and to understand, does that language actually resonate with people, or perhaps it might be different language altogether. But again, I mean, the whole point is that I don't think we need to get bogged down in arriving at the perfect definition first. I think we can, just think about our, pain. How in the world do you define pain? And if we spend all of our time focusing on how we're going to define the word pain, if you think about it, it's actually quite difficult to define. Then we would never move forward with the study of pain. We need to move forward and we need to address pain. And yes, we can begin to work on what are the dimensions of pain and et cetera as we're doing that. And in fact, research can help clarify those pieces. But at the same time, we don't want to get so bogged down in the words and et cetera and the language that's used that we don't actually push the field forward. Does that
That makes sense.
make sense?
Any other questions?
I'm curious about your hopes for this research. So how would you like to see the insights of these studies actually implemented or impact what's happening in the care of life and setting?
So some hopes. I mean, that's a big. I think one key hope would be that spiritual care would just be standardly integrated into all palliative care provision. And education in spirituality would be in spiritual care for, obviously it's going to cross many disciplines because there are many disciplines that need to be at least generalists, knowing how to ask, how to screen, how to refer, etc. would be a standard inclusion across a variety of disciplines, not just within the palliative care setting, but certainly that it would be within the palliative care setting, just a standard component. And that's increasingly actually the case. We're certainly getting there, but how to train people, who has what role, et cetera, how to work that out in a multidisciplinary fashion, I think is an area where we need further work to step forward. But that would be an initial hope.
I'll make that our final question. So, join me in thanking Dr. Balboni one more time. Thank you again for attending today. Please be sure to sign up for any CMEs or CEUs that are due to you, and staff and students from the Center for Spirituality and Health will resume with a staff meeting in Edinburgh 2551 immediately after this. Thank you very much.